An 89-year-old Caucasian woman, body mass index BMI of 17.2, with a known medical history of hypertension, rate-controlled arterial fibrillation, hypothyroidism, aortic insufficiency, lymphedema, and hypoxia secondary to partial lung resection on home medications of warfarin, levothyroxine, metoprolol, monoclast, and furosemide, presented to North Shore LIJ Plainview's emergency department at 2:30 p.m. after a witnessed fall not associated with head trauma or loss of consciousness. Her vital signs on presentation were blood pressure of 144/81 millimeters of mercury, pulse of 119 beats per minute, respiratory rate of 18 breaths per minute, temperature of 98 degrees Fahrenheit, and oxygen saturation of 85% on room air. Our patient's baseline oxygen saturation was unknown, and she denied being on home oxygen therapy. On physical examination, our patient was not wheezing on presentation, but revealed shortness of breath on room air with diffusely scattered rhonchi. An electrocardiogram, or ECG, revealed arterial fibrillation at 113 beats per minute, along with right bundle branch and left anterior fistula block. At 3:30 a.m., our patient suddenly became bradycardic and processed to estole. She was found to be pale and pulseless. Cardiopulmonary resuscitation, CPR, was immediately begun following an advanced cardiac life support, ACLS, protocol. Initial respiratory support with a bag mask was attained, and our patient's trachea was secured with intubation at 3:32 a.m. As per ACLS protocol, 1 milligram of intravenous epinephrine was given, followed by 40 milligrams of intravenous vasopressin given at 3:36 a.m. Our patient received her second dose of 1 milligram epinephrine at 3:40 a.m. Finally, at 3:46 a.m., our patient received 1 ampoule of sodium bicarbonate. Our patient remained unresponsive and continued resuscitation efforts, so CPR was abandoned at 3:48 a.m. Right femoral venous access had been attempted during the resuscitative efforts, and cardiac monitors were unwittingly left on our patient while cleaning and removal. At 3:51, before the complete removal of the femoral venous catheter, a single ventricular contraction was noticed on the monitor. This single contraction processed to a couplet and then a triplet, and finally into a normal sinus rhythm and a palpable pulse at 3:53 a.m. Her initial blood pressure was measured at 80/50 milligrams of mercury, and our patient was started on a norepinephrine drip at 10 micrograms per minute through the femoral venous access. A right femoral arterial line was also established for continuous blood pressure monitoring. Her blood pressure stabilized at a mean arterial pressure of 70, and our patient was transferred to our intensive care unit, or ICU, at 4:30 a.m. In the ICU, a hypothermia protocol was initiated, and vasopressors were titrated to maintain systolic blood pressure greater than 90 millimeters of mercury. Unfortunately, at 10:55 a.m., our patient went into ventricular tachycardia, and despite resuscitative efforts, our patient was pronounced dead at 11:03 a.m.